Welcome everyone who's joining us. How do I see that Tegrity's actually recording on here? Should there be a voice? I guess it is recording. Correct. It's monitoring, or it's showing, registering something. Okay, so we were on session 1, and do you know what slide number we were on?
165.
165. Sir?
You got that too. Confirm.
Okay, so welcome to everyone who is joining us live or streaming. You said 161? Are you sure?
It was the Rooster from Zantoma.
Let's see, slide numbers are not. It's thinking. It's not responding.
What was a good effort? See you guys next week.
Knowledge over.
Oh. Okay, I believe we are now recording again. Adam, you want an assumed name, or you want to go under your real name?
Sounds like my name's already out there, so my secret is not informed.
Okay, go ahead.
Alright, so this looks like inferior abdomen, probably.
Yeah, maybe sort of groin area next to the thigh.
Sure. And there's a shrivelly looking plaque of skin.
Yeah, so what would that suggest morphologically? What might not be intact?
The underlying dermis.
What portions of the connective tissue? What component?
Like the elastic tissue.
Yeah, exactly. I mean, it suggests that you've got elastorexis of some sort, right? So you've got a localized elastorexis. Does it look like an anetoderma, though?
No.
No, I mean, it's not pooching out,
right,
nicely ballooned like an anetoderma normally does. So what other things might you think of?
Well, I mean, it's not a good location for like an elastolytic granuloma.
Like actinic granuloma,
right.
So very good point. So actinic granuloma tends to be annular, tends to be sun-exposed skin, and have cigarette paper wrinkling within. This is more like a sac, a wrinkled sac hanging outward.
Mm-hmm. I mean, I'm kind of blanking, I guess, a little bit about this location and the morphology of it.
So,
for PXE.
Any other thoughts people might want to? Granuloma-like skin would probably be top of my list. You know, just because it really is a sort of a hanging, pendulous thing localized. So that would be the top of my list, and let's see, that's what it was. And again, some of these are contributed by Robert Wood Johnson School of Medicine. Some are used with permission from the Cutis image quizzes by permission of the publisher. So we acknowledge that at the beginning of each talk.
You still put that in with a variant of CTCL?
Yes, so granuloma-like skin will evolve either to CTCL or to Hodgkin's, but it can go either way. But definitely in lymphoproliferative category. So if people go to the first slide of when we kick off a new set of Kodachromes, it's got the link to the JAD image quiz and the Cutis image quiz, because we try to encourage people to do those because they're very good. Okay. Are you going as Christina is fine going under her own identity. Anyone who doesn't want that can just pick an alias. Okay.
This looks like a lesion on the scalp. I can't really tell the age of the patient, but it looks like they may dye their hair some way outgrowth.
Yeah. Suggests an older adult or a vein child.
Either one, you know.
Yeah, okay.
Others just don't like their light white.
Exactly.
I would put it in the neoplastic category. From this image, it's hard for me to tell for sure. I mean, definitely biopsy.
Correct.
Put it in, you know, with older people with lesions on, assuming she's a female, the men can dye their hair as well. You could think metastatic breast loves the scalp. I was thinking like the vascular neoplasm or X or an angiosarc or something.
It's a little bit plummish colored too, so hematopoietic certainly fits with that. Merkel also fits with that. So I agree with you, neoplastic, and this is one that, you know, although it doesn't look like much, you don't let it leave the clinic without a biopsy. And that's what you see. And, you know, so given that we have some ducts here, we have some solid areas. I wish we had a little higher view of this, but my guess would be we're looking at a malignant spiroadenoma. Okay. Are you going by 007 or
Clark Kent?
Clark Kent? Yes. Okay.
So you see basically reticulated hyperpigmentation, could be purpura. Looks like somewhat violaceous patch on an extremity of a Jefferson patient. So trying to tell if there's any epidermal change. I really don't see much.
So it looks like reticulated erythema fading to pigment, to post-inflammatory change. That's the way I interpret your description. So what things would be in that differential?
So like erythema ab igni.
So erythema ab igni certainly can do that. What else?
So vascular insufficiency from like medium vessel occlusion. Sometimes you
So livido pattern, of the things that cause livido, which ones fade to post-inflammatory hyperpigmentation and which ones don't?
more like occlusive rather than vasculitic.
So occlusive usually doesn't, is more transient or in nature. Whereas in the vasculitic realm, especially polyarteritis nodosa, is more likely to be longer standing and give rise to post-inflammatory change. So, good discussion, and I think that one was PAN. Okay. At least that's what I would put at the top of my differential until biopsy. Okay.
So it looks like we have reddish, purplish, flat top papules in the portion of the hand. As well.
And are they all discrete, or are there some areas where they merge in a linear fashion?
There are some areas where they merge in a linear fashion.
I see. And what might account for that merging in a linear fashion? What phenomenon? Maybe isomorphic, like there was a scratch there and you have some Kevnerization. Yeah. So flat top papules, and it looks like they have some tendency to Kevnerize. LP would probably be the top of my list. You know, they are somewhat over. It's not clear whether they're really on the knuckles or it looks like on the digits, some on, some sparing. You know, you might think of things like dermatomyositis in the differential as well, but probably LP higher. Other thoughts?
What about with multicentric reticular histiocytosis? Would that look?
So multicentric reticular histiocytosis, absolutely on the dorsum of the hands. You might see evidence of the associated arthritis in the digits. and usually not flat-topped or Kevnerizing. And the way there's a light reflex from these suggests surface atrophy or flat hyperkeratosis, which usually you don't get with MRH. But very, good thing in terms of description and morphology for these in particular. And that's what we see. And given that, what might you think now?
Those look like Wild West.
They certainly do. So multicentric reticular histiocytosis would go significantly higher on my list, given the biopsy. Well done, Katie.
Good idea.
Okay.
So we have exophytic vascular tumor on the extremity of the dark skin individual.
And I'm not sure if your voice is registering on here. So project from the diaphragm, and I'll try to repeat what you say. So exophytic, eroded, lesion, dark. What's your differential?
So something like a protein sarcoma, Merkel cell.
So KS, Merkel. What things give you dark pigment? So you mentioned some things that might have hemosiderin, like KS. What other things give you brown or dark pigment in skin?
Pigment incontinence.
So melanin. Melanin, hemosiderin, and lipofuscin would be another big one. So things with lipofuscin would tend to be sweat gland tumors, have lipofuscin, but that's usually just focal blue in those. This is more of blue-brown over the whole thing, or maybe greenish like a chloroma. You might have to think of that as well. This is same patient.
This looks a little more atrophic, kind of scarred down a little bit.
Yeah, exactly. So
like a DFSP.
So very different morphologies. And what I suspect is that although both are labeled A, they are not directly related to one another. So this one I would think is probably a melanoma eroded. This one, although it is probably a male, not a female, given the morphology and that appearance, what would you say it is? Did I hear desmoplastic trichoepithelioma? I think that's what I heard. So, usually cheek of a female, age is probably right. Someone who's around, 20s, 30s to present. The depressed central del would certainly be right. The horn cysts and the Paisley-Tie-like, but overwhelmingly female rather than male. So that makes the case a little unusual. Remember, clefting in an trichoepithelioma of any sort will be within the stroma, not a retraction space between tumor island and stroma. Okay, so, hard to see pathology here. Fungating friable lesion, so we're definitely in a tumor differential. And this was from JAD case reports. And, a horrible acral melanoma, obviously neglected.
So the exophytic mass.
Exophytic mass, I would think, would be melanoma. But, the exercise is to go through the differential, try to make as good and broad a differential as we can. And then if there's a surprise by path, that always pops up, when it's not what you might have expected in your or put at the top in your differential, then that's always going to pop up in words, etc. When nothing pops up, then it's usually what would be the top of our list, which would have been melanoma for that one. Okay, so how about this one? What do you see?
So it looks like there may be some, it's hard to see, but hyperpigmented pustules on the neck.
Okay. Yeah, so certainly not dramatic, but it does look like there is a little hyperkeratosis, a little bit of lichenification. If you compare this skin to that skin, there's accentuation of skin markings. So what things might you put in there? So in acanthosis nigricans, is it diffuse or is it more reticulated? Maybe confluent and reticulated? So what might that bring to mind? Yeah, so a Gougereau and Carteau type confluent and reticulated. Certainly if it were minocycline responsive, it has a pathology very much like acanthosis nigricans, so it would have a clinical similar to acanthosis nigricans, except that it's reticulated. If there were more atrophy in its sides of the neck, I might think of things like dyskeratosis congenita. I don't see much telangiectasia for either that or poikiloderma of Sabat. Okay, and that I believe was just a carp. Okay, next one. James going under an assumed name or not?
Just normal name will be fine.
Normal name will be fine? Okay, go ahead.
Not detecting a lot of pathology here.
Does that look like skin color?
It looks a little bit hyperpigmented.
And when you say hyperpigmented, would that be brown or gray?
Grayish, I suppose.
Gray. So that one might even say perhaps ashy in appearance.
So it'd be like an ashy dermatosis.
Like an ashy dermatosis. So what is an ashy dermatosis? And the patient came in because she was troubled. She said, and her friend said, you are turning gray.
Right. I'm bringing the other name for it now, but there's another name for it, and it's most commonly in people like Latin Americans.
So name because it begins with an erythematous phase, and then it is dyschromic and persistent.
Oh, yeah.
Like an erythema dyschromicum perstans or ashy dermatosis. Most of our names are just very descriptive of the presentation. But it's also synonymous excuse me, with lichen planus actinicus, lichen planus pigmentosus. It's all the same disorder. So in Latin America, it was described as ashy dermatosis, and that's basically the variant I saw commonly in Texas. This person is from the Southwest Asia, Middle East area, where it was described as lichen planus pigmentosis. LP actinicus and South Asian populations are essentially the same disorder. And some more discrete lesions, which, if you biopsy the gray area, all you really see is pigment incontinence and maybe a few mummified Sabat bodies, whereas an acute lesion will look more lichenoid. And others, so EDP. Okay, how about this one? Are you going under?
I'll be capital K,
So,
I get it.
This one, to me, what's really standing out is the background of the poikiloderma. I think originally called poikiloderma of Sabat, but I think now it's being changed to just poikiloderma.
So poikiloderma or poikiloderma savate. Poikiloderma just means hyper and hypopigmentation, atrophy, and telangiectasia. And if you look at all patients with poikiloderma, a significant number will fit into chronic actinic damage, which is basically poikiloderma savate. Others will fit into CTCL. Others will fit into connective tissue disease, especially dermatomyositis. And then others will fit into genodermatoses, especially dyskeratosis congenita, Rothman-Thompson a little bit, although it's not quite as atrophic. I'm sorry, go ahead.
Down there in the bottom right, is that just where the elastic fibers are kind of clumped up? It almost looks papular.
Or the possibility, if it were a DM patient, that those are flat-top lichenoid papules. So that would probably in this patient be worth a biopsy because I see light reflex suggesting atrophic flat-top papules. I would screen for other physical signs of dermatomyositis, certainly look for, it's not a big location for CTCL, but could be a location for DM, photosensitive. Patients may be a little older for presentation for a dyskeratosis congenita, which would be a young person, teens, 20s. Okay.
I guess in the pathologies, the kind of, somewhat reticulate hyperpigmented macules, fluorescent.
So we see them here, also there. This is probably just a bloodshot eye, and patients certainly too old for something like ataxia telangiectasia. So I agree with you. This is the likely presentation. Put it into, you think inflammatory or neoplastic?
No, I'm not thinking of something neoplastic.
Okay, so you put it into inflammatory category, and then more spongiotic or more interface?
Probably more along the interface.
I agree, more along the interface with the prominent pigment incontinence. So what things give you patchy interface on sun-exposed areas of the face?
Back to the thing we were talking about, just like the planus actinicus.
So LP actinicus would probably again be the top of my list. For this one, you run through connective tissue disease, all the other possibilities, but LP actinicus would be at my top. This is in a flexural surface, again, something not strictly sun exposed, but also pigmenting, and in fact spread all over the body in a follicular type distribution. So you do see patients who have lichen planopilaris presentation with an LP actinicus type presentation. And now I'm seeing it in areas where if this was all you saw, you might think of Dowling-Dagos and look for comedonal-like openings as well. But it was EDP-LPP overlap. So again, that's why people put this in the broad spectrum of lichen planus, basically, because you do see overlap of patients along the full spectrum of the disorder from lichen planus to LP actinicus, classic astrodermatosis presentation. These are also the patients who very commonly get MART-positive pseudonests. So you're biopsying something you're thinking is a hyperpigmented dermatosis, and the pathologist comes back as melanoma in situ. And, that's not what I was thinking at all. It can be a miscall because of the intense MART positivity of those lichenoid pseudonests. Okay, from JAD case reports. Again, these are basically the world's best. It's like getting to attend everyone's best grand rounds of the year. You see extraordinary cases and you see just really good teaching cases. So strongly encourage everyone to go online. They're all archived. Every QTIS online image, every JAD case report. You can go back and in a weekend morning do tons of cases. Do your own virtual grand rounds. Okay, so this one, how would you characterize the lesion? Neoplastic and probably the cutaneous horn, right? So causes of cutaneous horn most commonly.
Verruca versus squame.
So squame, verruca, trichomoma. This one most likely squamous cell carcinoma. Okay, Clark.
So there is a hint to safety violations fuel among the diffuse patch. This little second toe.
And are the other toes normal?
No, they're not. They're also kind of have the same kind of thing.
So there is distal, slightly dusky erythema on the toes. So start coming up with differential.
So about pernio.
So perniosis, absolutely. And if the biopsy were to support pernio, or if the clinical supported pernio, your first screening test would be anti-nuclear antibody, because that is presentation for a significant number of people with lupus. Okay, if not perniosis, then what other things might you think?
What I think about, and perhaps I think this would be very atypical presentation for Raynaud's. But I think Raynaud is more kind of just that straight line of
correct. It's a little bit localized distally for Raynaud's phenomenon. So what else?
You potentially have an embolic disorder that is.
So embolism of some sort in an older person, cholesterol embolization. You might look for renal compromise and livido on the distal extremity. Septic embolus. Anything in the infectious group?
Yeah, I think about viral.
So viral exanthem, in reactive, maybe an acral erythema, although it's a little bit more on the dorsum of the hand than you might expect with an acral erythema. And then this is your path.
A lot of prominent papillary dermal edema.
So papillary dermal edema, and do the lymphocytes sit on a background of pink, or are they surrounded by white?
They're surrounded by white.
And so lymph surrounded by white in a vessel is description of fluffy edema. So if it's on an acral surface with papillodermal edema and fluffy edema in the vessels with lymphs, then you would think perniosis at the top, which is exactly where you started and what it turned out to be. Okay, so we will occasionally show appalling images, and the question is, what was done wrong when the photo was taken? F-stop said incorrectly, so which means that the camera was put on automatic, right? So someone bought a very expensive camera, set it on automatic, and wants to know why none of their photos turn out. Because if you take an expensive camera and put it on automatic, you will get an f-stop about 2.5 or so when you're trying to do close-ups, because it thinks you're trying to take a picture of a flower with everything else out of focus. Whereas you want to set your f-stop either AV priority or manual to 18 to 22. I just leave mine on 22 f-stop. And if you have through the lens metering, your light's going to be just fine and everything will be in focus. And that's basically it for that one. Except that we have a path to go with it. And we need to tilt the projector because I believe your path is down right at the bottom of the screen. Those online can see it better. But right there and there is probably what we're looking at. So what things might you be thinking at? Someone want to jump in? So, I mean, what you had clinically is not much other than you can make out that it's periumbilical, right? So these are periumbilical, maybe bruise-like periumbilical. And then you have something, is that something that normally belongs in the dermis?
It's not endometriosis.
Oh, no, I'd be thinking that's some kind of larval worm, like strongyloides, because we're periumbilical. Exactly. So strongyloides would be my first concern, and especially because we are in the South. Southerners have worms because the climate is milder. And there was one study where at Duke Medical Center, it was the most common disease among immunosuppressed cancer patients. Was their strongyloides, which they walked around with, but well compensated and then potentially fatal. So.
Gut you're seeing in there?
Yeah, see the little stippled interior here? That suggests that you have microfilaria. And that is from Misha. This has been widely published. Okay, and another patient.
So, admin, we have use, service,
and Misha, thank you for sharing that case, and my apologies for referring to the photograph as appalling. The histopath was wonderful and the case was dramatic. Okay, David, go ahead.
Kind of a bad like distribution survey of well. Looks like it's chloroform, there's a drug reaction, viral symptom, could be really bad. Contact dermatitis.
Okay, so we had viral exanthem. Contact, it looks like maybe a little petechial in there, so I put that further down on the list. The abdomen is a little protuberant, could be just a beer belly, or could be maybe a pregnant female. And then you might, if that were a pregnant female, I don't see them clearly in stria, but then you might bring up things like PEP, polymorphous eruption of pregnancy, or many of us still say POP, and either one, PEP or POP, everyone knows what you're talking about. If they're not clearly in stria, then herpes gestationis, pemphigoid gestationis becomes more likely. So let's see if we can get a little history. There is no additional history, so I think this was a POP case. Okay, how about this one? Also contributed. This is not my slide.
So it looks like you have scarring alopecia scalp.
Looks like marching backwards, so you might think of frontal fibrosing, absolutely. Okay, this also was contributed, so this is not one of mine.
So it looks like they're two pretty sizable ulcerations here. Jump at the bottom.
Okay, so ulcerations and things that you might think of.
So in this area, like in the nose, like that, think about zygomyces.
Oh, so a zygomycosis in the infectious category.
Right.
Does this look acute, or does that look like it's had time to scar?
Oh, that looks scarred.
So if it's unless they're two distinct processes, probably not zygomycosis, because that would be hyperacute and patient wouldn't live to scarring, probably.
So then we'd go like more neoplastic, probably.
So neoplastic, but two widely separated spots. And is it round or is it somewhat angulated?
It's angulated.
And angulated usually suggests an inside or an outside job?
Well, in some, like geometric suggests outside, angulated can suggest like underlying
So
vasculature.
angulated, if stellate, could be stellate or retiform, could be endogenous, suggesting an arteriolar disease. This might be a little more on the geometric side, where you might think that there's an exogenous component.
Yeah.
So what kind of things do you think in differential?
Factitial.
So factitial, or what if something that's driven by an underlying sensation, but
trigenital trophic.
Like a trigenital trophic would probably be top of my list. It could be post-zoster. It can be basically like a neuralgia equivalent. Right. It can be post-stroke. It can be any of those. So trigeminal trophic would be at the top of my
I've never seen two sides
list.
of that.
Yeah, usually it's just side of the nose, but that is, and I don't, because this was contributed, I don't know the details of the history in this one.
All right. I feel like I'm back in the differential that Sean was going through earlier. Excuse me, Clark was going through earlier.
Okay, everyone's taking notes. Clark equals Sean. Okay, continue.
So, with just it has to me, the purpley color that makes me think about like Pernio or chilblains, but.
So a violaceous color making you think of Pernio or chilblains. Does it extend beyond just the purple toes?
It does. So you have sort of more reticulate purpuric lesion on the sole of the foot, and the fact that it's only involving the two toes, I think also kind of puts me more towards like an embolic, vasculitic.
So now we're into the possibility of retiform purpura, cholesterol emboli, something that would occlude or involve an acral vessel, and I agree, I would put that at the top of my list, and that's what you happen to see histologically.
You had a stent or something placed a few days ago.
One would think either that or recent anticoagulation resulting in the patient's cholesterol embolization, and the organ system most likely to be affected systemically, other than skin, kidney.
That's right.
Yeah, because it's embolizing kidney. Your skin and your beans are getting embolized. Okay, another contributed slide.
So, see kind of a diffuse, kind of pink to slightly violaceous erythema on the chest, neck, arms. Some of these areas are crusted.
Someone who you assume would be walking well? No. I mean, they look like they're ill, inpatient.
Number of lines.
So suggest someone who's probably on oxygen and lines.
So trying to look for like intact, like vesicle or anything.
So go with broad categories as Dr. Mays leads you. So do you think anything neoplastic?
I mean, it could be
So probably about the only thing in the neoplastic would be MF type lymphoma, right? Other things that would be more likely, other categories.
Just like inflammatory reactions.
So inflammatory skin disease. How about infectious?
I mean, nothing's really jumping out at me.
Okay, so let's look. That's also on the same patient. And it was a cytotoxic lymphoma. So again, this is one obviously you would biopsy for, and you would, if you were confronted with the patient, you would have to run through all of those categories in some critically ill, infectious things, and for MF type category, the necrosis was out a little bit incongruous with MF, but for a cytotoxic lymphoma would make sense. Okay. How about this one?
So, crusted, eroded, back on the bilateral feet.
So bilateral feet, volar or dorsal? Dorsal feet. So you think contact derm to rubber allergen?
I mean, I guess it would possibly think they're more of their entire, like their volar surface would be their dorsal.
So volar would more likely be mercaptobenzothiazole.
Okay.
Things like Thioram, Carba that are box toe type of things in the shoe usually are forefoot or just dorsum of foot up to ankle. Little odd for contact, right? Unless it's a boot. I suppose it could be a boot allergy.
You could think like infectious as well, like tinea, that they, but I don't really see interdigital spaces being infected.
So tinea may be less likely, but certainly if there is scale, you would want to scrape it.
Like a nutritional deficiency, like necrolytic.
So necrolytic acral erythema, and is necrolytic acral erythema glucagonoma nutritional associated, or is it Hep C associated? So acral erythema would probably be at the top of my list. But if very itchy and the person wears boots, then maybe contact allergy. And this was necrolytic acral erythema. Okay, this was from one of the groups, one of my fellows, Nathan Cleaver, shared this with me. His residency program and then his dad's practice, they both do medical mission trips, and found this child who progressed from a PMLE-like picture with scarring to these crusted ulcerations. So what would you worry about in an Amerindian type of population where you have a child who begins with a photosensitive dermatosis, and then it could simply be impetiginized, but if not responding to antibiotic. So Phogosovagum, you're thinking regional geographic, which is great. So Phogosovagum can be any age, but commonly adults, and is going to look foliaceous like. So the crusting, dried cornflake crusts you could get, but doesn't usually start with a photosensitive eruption. So when you have a photosensitive PMLE-like thing that scars, what are you thinking? Hydroa. And then hydroa that starts to ulcerate and crust in a child, you think of, hydroa-like lymphoma. That's absolutely correct. So that's what the concern would be. And then the slides came to us in New York, and that's exactly what it was hydroa-like lymphoma. And I just got pictures of her under treatment, and she is clear.
Wow.
So I don't remember what she got for chemo, but so that's the presentation, a hydroa-like appearance, and then ulcerations, which would make you think the lymphoma. There was histology, and here are angulated hyperchromatic cells rimming the lymphocytes, which is lymphoma. I mean, this usually is a cytotoxic lymphoma, which is why it's destroying tissue. And EBER positive. So EBV associated. So hydroa-like lymphoma, and the follow-up was she is clear and doing well. Great credit to them and the work they do. Okay, who's up next?
Multiple hyperpigmented.
Yeah, so this is another contributed slide. So if this were necrotic on an ear like that, if the person had retiform purpura and necrotic areas on the ear, what recreational things might you think the person is doing? Cocaine with levamisole necrosis. But what if this is instead itchy like crazy? Then what recreational, healthy activities might the person be engaging in? I'm sorry, what? I missed it. It must have been good. Oh, meth. I'm not sure that meth would fall into the healthier recreational activities. But what if this were exogenous? Someone, I think I heard Toxicodendron rus. Remember that whole poison ivy family leaves black lacquer? It's related to the lacquer tree and, leaves black streaks. So you might think of that as well, which is what this was. Also courtesy of Tutus.
Atrophic large patches, pink to browns, and violaceous as well.
So pink to brown violaceous, definitely hyperpigmenting, segmental in distribution. So you brought up the possibility of morphia. And these are two patients with similar disorder, I believe. Also hyperpigmenting, some linearity to the pigment. And there's a path. I see a subacute horn. So this is what's referred to as a this week sign. The bottom is red, the top is basket weave. The opposite would be a last week sign if there's parakeratosis above and normalized keratin below. So suggest this is a subacute process. We have a little bit of a polymorphous infiltrate with some neutrophils, but lots of dead reds. So when you see scattered dead reds like that and a neutrophilic infiltrate below, you can get either one of those, but it does bring up various possibilities. Connective tissue disease in its acute stage can be neutrophilic, but another thing, especially in someone who has a high sed rate and a sky-high ferritin, stills, absolutely. So stills in its acute urticarial phase can be neutrophilic disorder, neutrophils with relative absence of karyorrhexis, although I see some karyorrhectic debris here. And then stills in its later and papular stage can be all dyskeratotic cells in the epidermis. Looks almost like an adult with IP, with all those individual dyskeratotic cells. Think stills. And this is another later stage. And when you see these whorls of keratin up in the epidermis with dyskeratotic cells, that's diagnostic of stills. You got your diagnosis right there. So again, stills goes through life phases, and you have to recognize each phase. So there's the acute neutrophilic phase, looks kind of like urticaria or in that it has no karyorrhectic debris. Differs from vasculitis in that there's usually very little karyorrhectic debris. And then the dyskeratotic cell phase, and then they pop out into the corneum. So I would think stills for that. And here's your lab. So sed rate on both patients, sky high. Ferritin, look at that one. So you see, ferritin, I've been told, may be an even better screen for stills than a sed rate. Just because it's an acute phase reactant and tends to be super, super high on stills patients. Okay, yet another contributed. So this is, I sort of filled out the end of set one with a lot of contributed cases. We'll be back to most of my cases in the other lectures. Okay, so what do you see here?
So we have some erythematous patches involving the usage methods on the website. So basically, PIPs here, the mail changes, looks like onycholysis,
So you have some erythema over the joints, and you have distal onycholysis.
think about tissue disease.
So connective tissue disease would certainly be high. Irritant dermatitis you'd have to consider. Acral erythema, but this appears more dorsal than volar. Some sort of viral exanthem you could put in your differential. And this was acrylate induced. So, that's a good discussion of differential. Things that, this probably wouldn't, maybe unrelated, but psoriatic nails, you'd expect some scale here. Certainly can give you distal onycholysis. Thyroid absolutely can give you onycholysis, photoonycholysis from drugs such as doxycycline. You will always culture candida, but the candida is probably never the primary issue. So you may have to address it to get them to heal, but always look for some other underlying cause, be it irritant or other. So the group in Miami has published that patients, even when you're culturing candida, they do better as a rule with steroid than with anticandidal agent because the irritant, the dermatitis is primary and the candida is just secondary colonization. Okay, and with that, let's see what number we are on because I think we are out of time for today's. So we will be signing off, and we are on number 227 to start if people can put it in their cell phones.